We would now like to move ahead to our next session. I'd like to invite our chairperson, Dr. Malay Patel, and Dr. Prabhu Prem Kumar to please join us on the stage and take us through the next session, which is on international perspectives in venous practice. Post this particular session, we also have another interesting competition, and we would want all of you to join us back here. It's going to be exciting, it's going to be interesting, which is sponsored by Serbia, and it is looking out for Young Researcher Award. So we will have young researchers who are stepping up and presenting, and it's a competition. I'm sure it's going to be exciting, and I'm looking forward for it. As of now, this particular session is on international perspectives in venous practice, and that's why I'll hand over to the chairperson on stage. Over to you, sir. Requesting the speakers to hold the mic as close as possible. Over to you, sir.
Good afternoon, everybody here, and good morning, good afternoon, good evening to our international speakers. And we start the international perspectives in venous practice. We have 5 speakers today, and we will start with Dr. Peter Subramaniam from Australia. So he's probably, it is late evening for him. And so can we have Dr. Peter Subramaniam begin his talk? Is Dr. Peter Subramaniam online?
Thank you for the opportunity to share the current Australian perspective on the management of venous disease. The Australian-New Zealand Society of Vascular Surgery is appreciative of the invitation of the Venous Association of India for this opportunity. Like in most jurisdictions across the world, endovenous treatment of superficial truncal venous disease is increasingly represented in cases recorded on the Australian Vascular Audit. Although at 41% of total number of cases done in the last 5 years, this is likely to be an underrepresentation of the true breakdown of endovenous versus open treatments. This is because a large percentage of venous disease is treated as ambulatory, non-hospital-based care, and also in the private sector, where data is variably captured in the Australian Vascular Audit. Surgical ligation and stripping continues to be performed in many public hospitals, although this is increasingly a diminishing activity. Over 90% of endovenous interventions are of a thermal ablation nature, either with radiofrequency or with endovenous laser. In 2017, the Commonwealth Government of Australia commissioned a review of payment schedules for all services provided through Medicare, which is the universal health system which provides health care to all citizens of Australia. Data on 77,000 varicose vein services were analysed, and this confirmed a trend of a decrease in surgical ligation with a corresponding increase in endovenous procedures. Over 60% of procedures, however, were claimed for injection sclerotherapy. As you would expect in a country of our size, regional variations exist, with the expected preponderance of services in the more populous East Coast cities in Australia. Remote and regional areas are again underrepresented in cases managed by endovenous technique. The Australian and New Zealand Society for Vascular Surgery commissioned the development of a web-based national audit in 2010. The audit has matured in the last decade and provides us with the capacity to study and analyze the trends in management of vascular disease in Australia. Participation in the audit is a mandatory requirement for membership of the Society. Useful data is harnessed from this audit, and when we look at endovascular procedures, we are able to make some comment on the treatment of deep venous disease. What you can see here is the increasing numbers of venous stenting demonstrated in this graph, with annual case numbers noted. The increase coincides with the publication of the ATTRACT trial around the 2017 mark. Certainly, access to venous-specific stents, the use of IVUS, and the attendant significant interest by industry has seen the increasing numbers. However, it should be noted that a significant number of interventions performed in the private sector are not captured in the AVA, or the Australian Vascular Audit. Again, there's a preponderance of activity in the east coast of Australia, with a significant number of cases being performed in the private sector. That is not captured in this data. The pattern of deep venous intervention is consistent with the literature, with the preponderance of females and involvement of the left iliac system. Approximately 90% of interventions are elective, as reported in the national audit. A very, very high number, 72%, relate to the intervention for an underlying diagnosis of May-Turner syndrome. Data capture does not allow us to make comment on the methodology of diagnosis of May-Turner syndrome. 27% were conducted for claudication and ulceration. Of the 10.5% or so of semi-urgent and emergency cases, 18% was associated with catheter-based thrombolysis and 13% with the use of the angiojet catheter-assisted thrombectomy device. The evidence base for venous stenting for non-occlusive venous disease, or so-called NIVOS, remains an active element of discussion in Australia. While venous stenting for patients with ulceration and venous claudication is generally accepted, the use of stents in minimally symptomatic or subjectively symptomatic May-Turner syndrome remains an ongoing topic of debate. Certainly, vascular units in Australia with particular interest in venous interventions have developed excellent competencies in the use of intravascular ultrasound and the deployment of venous stents. However, the criteria for intervention and the subsequent follow-up continues to be a work in development. Cost associated with the intervention, together with the clinical improvement provided by venous stenting in cases of external compression associated with chronic occlusive anatomy, is justified in our view, especially in cases of gross post-thrombotic swelling associated with ulceration. Certainly, Australian vascular surgeons have been active and involved in research and publication in this area. With the innovative use of endovenous technology, sometimes endovascular technology, such as reported in a case study by my colleagues at Flinders Medical Centre here in Adelaide. The economic burden of chronic venous ulceration is no different in Australia than in other parts of the world, and certainly the driver to minimize post-thrombotic syndrome and treat ulceration remains a significant driver in this area. The evidence base for any surgical or endovascular intervention remains an important tenet of vascular and indeed any surgical practice, not just in Australia but around the world. The absence of an evidence base can lead to ethical and medical legal issues when late onset or delayed complications such as stent thrombosis occur. To summarize, as with the rest of the world, Australia has moved to developing ambulatory, minimally invasive thermal and non-thermal techniques for the management of superficial venous disease. The ANZ Society, through our subcommittees, are involved in the assessment of the development of specific identifiable reimbursable item numbers for ultrasound-guided truncal sclerotherapy. It is the Society's view that the endovenous management of superficial venous disease is appropriately and adequately guided by duplex ultrasound, and the use of venography is not required or only required in a very minimal number of cases. This is the position we've put to the government. Like all other parts of the world, the Society encourages its members engaged in deep venous intervention to contribute to the literature by the development, for example, of multi-center independent registries with focus on clinical outcomes, standardization of interventions, and measurements on IVUS and so forth. And also consider the cost effectiveness, both in the public sector, but also in the private sector, where a significant number of deep venous interventions occur. Once again, I thank you for the opportunity to present to the Venous Association of India.
Thank you, Peter. Thank you, Peter, for that illuminating talk. Now we will move on to the next speaker, who's from Italy. It's Dr. Patrizia Puvai, who's been the past president of the Italian Phlebology Association, as we put it in English. So Patricia is going to talk to us about an international perspective from her viewpoint. And Patricia, you can please start your talk.
Good afternoon. My name is Patrizia Pavei, and I manage the Vein Center of the Day and Week Surgery Unit of the Padua University Hospital in Italy. And I will share with you our perspective in venous disease. In Italy, we have 20 regions, and each region has different rules for the reimbursement of the treatments for chronic venous disease. Nevertheless, the Italian health service has given some indication about the appropriate treatment and setting to be used, taking as a reference the suggestions coming from NICE clinical guidelines. As regards the setting, to be cost effective, the management should be performed on an outpatient basis by a vascular service with a team who have the skills to undertake a full clinical and ultrasound assessment and provide a full range of treatment. Furthermore, following the same guidelines, the first choice treatment for varicose veins should be endothermal ablation. Ultrasound-guided foam sclerotherapy should be considered as second choice, and only as a third option, surgery. Despite these suggestions, you can see in this slide that in 2019 in Italy, high ligation and stripping was still performed very frequently, and in 4.5% of the cases, patients were hospitalized for more than 4 days. This is due to the fact that the venous disease is very often treated by general or vascular surgeons not experienced in this field. On the contrary, in Padua, we focused on the treatment of venous disease since the 90s, and in 1986 we started as an office-based surgery. Then in 1992 we became a day surgery unit, in 2000 a freestanding unit, and in 2014 we have been incorporated as a vein clinic within the multidisciplinary day surgery unit of our hospital. In our phlebological unit, we performed every kind of activity connected with venous disease. In the ambulatory setting, we evaluate the patients both from a clinical and instrumental point of view. Echocolor Doppler and plethysmographies are carried out by doctors, as well as ultrasound-guided foam sclerotherapy. The other endovascular treatments and surgery are performed on an ambulatory basis as a day surgery procedures, and we perform endothermal procedures, laser and radiofrequency. And among the non-thermal, non-tumescent procedure, we use cyanoacrylate glue. Only in selected cases, we still perform high ligation and stripping. How do we choose between the treatments? In summary, we prefer ultrasound-guided foam sclerotherapy for smaller veins with a diameter between 3 and 6 millimeters. In older patients, in women in childbearing age, or in patients with few branches in both, we use ultrasound foam sclerotherapy. And in these patients, also cyanoacrylate treatment can be considered. For bigger veins, between 6 and 10 millimeters, affecting more with disease affecting more branches, we, with medium to strong reflux, we suggest glue or thermal ablation, while for advanced disease, we use thermal ablation or, in rare cases, traditional surgery. In most of the cases, we use more than one technique. For example, when treating big recurrent varicose veins, we associate ultrasound foam guided sclerotherapy with phlebectomies. Glue and endothermal ablation can be combined with sclerotherapy or phlebectomies, and high ligation and stripping can be associated with sclerotherapy. So, which is the best treatment for venous disease? In my opinion, it is a balanced choice taking into account clinical guidelines, international guidelines, evidence-based medicine, advantages and disadvantages of each method, considering the experience of the doctor and the preference of the patient, and keeping in mind that our treatment should be cost effective. We can conclude with the sentence of Bo Eckloff of a leading article published in 1988, who said, "The modern surgeon treating varicose veins should have a Doppler in his pocket with a knife in a hand and a syringe in the other." In other hands, we can say that our vision is to perform a tailored treatment. Thank you for your attention.
Thank you, Patricia, for that overview and the final message that goes through. It is very clear to almost all phlebologists or anybody who is treating varicose veins or superficial venous reflux, as we call it in general terms, that a combination of therapies works best and tailor-made therapies work even better. So thank you, Patricia, and we now move on to the next speaker, who is Dr. Javier Zaralde from Mexico as we call it, but Mexico as they call it. And Javier, very, very good morning, because I think it is 3:30 a.m. or something like that for you. And we are very happy that you have chosen to stay awake or wake up to talk to us. Please go ahead, Javier.
Hello to everybody, I'm Dr. Javier Serralde from Mexico City. First, I want to say thank you for the invitation to me. In this moment, I want to tell you about how to understand the pelvic venous disorders. Well, I don't have any conflict of interest about to talk this topic. When we decide to understand what happened with the venous pelvic congestion, it's mandatory to understand the definition because this is the increase in intrapelvic venous structures in number and caliber. It has the varicose and tortuous morphology with the flow out alterations. And it's very important to remember the chronic pelvic pain more than 6 months is the main symptom in these cases. About the incidence of the pelvic venous disorders, in 2019 the UAP published the consensus and they can identify the pelvic chronic pain in 39% of the women. The pelvic congestion syndrome is estimated in approximately 30% in the patients with pelvic chronic pain, most commonly in the reproductive age between 20 to 45 years, and the risk factor is the more pregnancy, more incidence. And the true real prevalence of the pelvic congestion syndrome is still unclear. About the backgrounds and reviews, we can get in the Cochrane Library only 32 trials and 2 reviews in the last 4 years. Speaking about the pelvic venous disorder, how to get started to understand the pelvic venous disease? We need to use the 3 points. The first is to know the abdominal and pelvis venous anatomy, the second to understand the venous pelvic pathophysiology, and the third is to identify the symptoms and things in venous pelvic disorders. Speaking about the first point, the pelvic venous anatomy, we need to identify the inferior cava vein, the gonadal veins, the common iliac veins, the external iliac veins, and the internal iliac veins with the extrapelvic and intrapelvic branches. The main part is to identify the branches from the internal iliac vein because we can identify the extrapelvic branches like to the gluteal veins, ischial, internal pudendal, and obturator veins. And in the intrapelvic branches, the most common affected veins are the uterine and vaginal veins. Speaking about the venous pelvic pathophysiology, it's mandatory to understand that in this pathology we can identify the venous pelvic hypertension. Can be produced by the reflux syndromes, for example, the gonadal and internal iliac veins. It's possible to produce the pelvic varicose veins with the real pelvic congestion syndrome. On the other hand, if we can identify the compressive syndromes like Turner syndrome or Neutral-Caickel syndromes, we can identify the incompetent pelvic floor and the leaks to the lower limbs. In this case, we can identify the bulbar and atypic varicose veins of the legs. Speaking about the collaterality between the pelvis and the lower limbs, it's mandatory to understand 2 branches. The first is when we can identify the first problem provided from the gonadal veins, we have identified the insufficiency in the wrong ligament vein. In this case, we can identify the bulbar varicose veins. The other part, we can identify the main problem from the internal iliac vein. We can identify insufficiency in the internal pudendal vein, obturator vein, and the inferior gluteal vein. In 3 cases, we can identify the typical varicose veins in lower limbs. When we can appreciate the problem and the insufficiency from the gonadal veins, we can view damage the wrong ligament veins. In this case, we can identify the varices in the inguinal and anterior thigh. When we identify the problem from the extrapelvic branches, we can identify, in this case of the internal pudendal vein, varicosities in the inner thigh and vulva region. From the obturator vein, we can identify the veins in the pubic region, inner tight, groin, and perineum areas. And when we have problem in the inferior gluteal and ischial veins, we can identify the typical veins in the posterolateral aspect of the tight and infragluteal region. About the clinical data, when and why need to think in chronic pelvic venous disorder? When the patient has a chronic pelvic pain more than 6 months, aching or draining pain on sitting or standing, and the deep dyspareunia with another symptoms and things. About the diagnostic and treatment, it's very important to identify the chronic pelvic pain. In these patients, it's mandatory to perform the venous ultrasound in the abdominal and the leg area, and it's so important to perform the transvaginal ultrasound. We can complete our study with angiotomography or magnetic resonance, and the best part of the study is to perform the phlebography, because this is the gold standard. When we can identify the leaks, we can treat with cold embolization. And on the other hand, if we view the compression and thrombosis, we can treat with stenting. As a conclusion about the pelvic venous insufficiency, I want to say to you that the pelvic congestion syndrome has a 30% of prevalence in the population. This is an underdiagnosed disease. All of the patients with chronic pelvic pain need to be studied. Increase the teamwork with the gynecologist. The transvaginal ultrasound is mandatory, and the phlebography is the gold standard. About the treatment, the endovascular treatment, cold embolization, or stenting are the best therapeutic strategy. Anyway, this is all to me, and thank you very much for your attention, and this is the invitation to our next international meeting in Mexico in September, and don't forget the next 19th Pan American Congress of Phlebology and Nymphology in Ecuador. Thank you.
Thank you, Javier, for that difficult topic that you did try to make us understand much better. And we now move on to the next speaker.
Before we go on to Sandeep Rajpande, can I just request the tech team tell us who all are logged in from the speakers? All of them. Excellent. Welcome, Sandeep. We look forward to your presentation on the internet venous perspectives from Nepal.
Namaste, I am Dr. Sandeep Rajpande from Nepal. Thanks for introduction and thanks for invitation by BICON 2022. Hope I could have done it physically, but due to recent years travel, I plan to do it virtually, and I have also some local events in Kathmandu. So my talk today is surgical management of venous malformations. Among vascular malformations, the predominantly venous malformations represent the majority of cases. They form a clinical entity and therefore need clear concepts concerning diagnosis and treatment. See one venous malformation in forearm, just before nearby wrist. So surgery is indicated in isolated symptomatic venous malformations or the following sclerotherapy to improve form or function appearance. So surgical results are a function of the size and location of the malformations. Recurrence following surgery is more common with different malformation, and when excised is incomplete. In general, surgery or sclerotherapy is more successful when dealing with pure venous malformation than when dealing with combined venous malformation, combined malformations, AVM or lymphovenous malformation. A study by Kang and work involving 109 patients with slow flow venous malformations determined that total excision could generally be carried out in venous malformation, but that only partial excision was typically possible for lymphatic and combined vascular malformations, with lymphatic malformation in many cases not being operable at all. According to Hamburg classification, predominantly venous malformations are categorized into truncular and extratruncular forms, with truncular forms distinguished as obstruction and dilatations, and extratruncular forms as limited or infiltrating. This is the type 1 truncular forms, where the marginal embryonic vein was involved. This is a marginal lateral embryonic vein, which is a persistent fetal luminant vessel forming the failure of normal involution. This is surgically exposed marginal vein along the lateral aspect of knee and lower thigh before the surgical incision to control the venous hypertension due to severe reflux caused by avasculosis condition. This is the type 2 extratruncular venous malformation with the lesion in the right inguinal region. The lesion is a cluster of primitive vein tissue in infiltrating condition to the surrounding soft tissue without direct involvement of the main venous trunks. Mainly surgically exposed lesion which complies with N-butyl NVCA glue. So there are also intramuscular venous malformation, often erroneously called intramuscular hemangioma, which present to pediatric orthopedic surgeons as a different diagnosis of tumor or as a cause of muscle pain. So this is the intramuscular venous malformation in the calf. You can see on the MR. So surgical approaches utilize different tactics and techniques that are adapted based on the pathologic form and type of malformation. One is operation to reduce the hemodynamic activity of the malformation. 2 is operation to eliminate the malformation. 3 is reconstructive operation. A staged surgical treatment is also required in some selected cases. As for type 1, a type of tactic is the operation to derive the venous flow into the total or partial removal of the venous malformation and demonstrated subdivided into 3 different techniques. In this way, the infiltrating as well as the limited forms can be treated. An additional technique dedicated to the treatment of marginal vein. Approach 3 involves the treatment of venous aneurysm, where a variety of techniques have been successful. This is a venous malformation in the right lower limb involving persistent embryonic lateral marginal vein of leg. So results, long-term follow-up demonstrates positive results in 90% of the cases. This was a young man, waiter, KT syndrome with venous malformation. I did several steps of embolization, sclerotherapy. Then further I also excised some malformation because you are having painful. And finally he got leg before the treatment and after treatment few weeks, and he is doing good today. This is another lymphovenous malformation which I directly excised. Another beautiful lady with KT syndrome having venous malformation leg and foot. So leg was sclerotized, but foot was even painful after sclerotherapy, so it was excised. And I see her now, beautiful foot. So this is another boy, a student, 20-year male, who has this big venous malformation on left side, just above knee. And I did several steps of sclerotherapy and also embolization with polycanal and this lipidol. But he was telling no, he is again having pain and doesn't look good. And we did again the angio, and it was like 90%, more than 95% thrombosed. So with the help of plastic surgeon, we totally excised it, take it out, and he was very happy. So this is the staged one, no, the venous malformation in right lower limb treated by staged surgery with good results, multiple time, before and after. So this one is also on the one hand, before sclero and schism. Just be happy, excised and good lips. So as a conclusion, I would like to say venous malformations should be treated according to the principles developed during the past decades in vascular surgery, intervention treatment and multi-disciplinary treatment. The days of preemptive conservative treatment should be relegated to the past. Especially skills and experiences are necessary to carry out appropriate surgical strategy, and the required operative techniques should be dictated by the location and type of venous malformation. Surgery, when performed by a surgeon with appropriate experience, is an effective first-line treatment for painful intramuscular venous malformation, offering pain relief in the majority of cases. The majority of lesions are resectable, meaning they can be removed with a margin removing a functional limb. Sometimes resection of whole muscle is required. Thanks Vacuum 2022. All the best for Vacuum 2023. Thank you.
Thank you, Sandeep, for giving us a perspective, your perspective about treating predominantly, vascular malformations that are predominantly venous and with good outcomes. we will now move on to the next speaker, who's Alan Davis from London. And Alan is probably, it's a little bit good time, better time for him. So welcome, Alan. You've been here most of the times. We didn't see you this time, but that's, hybrid is good in that way. So please move ahead and give your talk.
Thank you very much for the very kind offer to talk about an international perspective from the UK experience. We have to consider patients with varicose veins, ulcers and various forms of arthritis. We undoubtedly know that the burden of vascular disease, venous disease is becoming more common. If we look at this data, you can see that the number of procedures being performed are increasing, and also the number of patients presenting with VTEs increasing. This is also very important because we know that venous disease affects quality of life, and certainly within the UK healthcare budget can account for 3 to 4% of the budget, and that patients with venous disease are more likely to be depressed and anxiety. We also know that it has a significant global impact, and it was predicted that $400 million would be spent on treating veins in 2021. So I'd like to think about talking about 3 particular areas: the optimal management of venous ulceration, the merits of superficial venous intervention, and something about VT strategies. We're all very familiar with the leg ulcer. Probably the key thing is the pathways that we use to do it. There's a lot of data that has come out of the UK, such as the ESCAR trial, the various venous trials, all looking at the role of compression and also surgical intervention. The ESCAR trial was the first major study that came out and showed that there was a benefit with respect to leg ulcer recurrence and heat recurrence. Then it was the EVERA trial that came out very clearly with evidence that not only was there benefit with respect to leg ulcer healing, but there was also a benefit from leg ulcer recurrence, and the long-term data out to 5 years showed a benefit with respect to ulcer healing, reduced ulcer recurrence rate, and that it was a cost-effective strategy. And very bluntly, we need to be looking at having a global pathway, a bit like a cancer pathway, which is a 2-week pathway where patients have their diagnosis, they're treated in the community with compression, they're then assessed by vascular surgery, and then they have their venous intervention. And this has certainly become something that has even reached the members of parliament and being implemented. There are many myths about the management of varicose veins, and I think it's very important that we are well aware of what these myths are, and we should know how to discuss them with our patients. Firstly, one of the major issues is what are the symptoms of varicose veins, and there is interesting data from the Edinburgh Vein Study that actually itching is probably one of the most important symptoms that one needs to think about. And what is also important is to note that there is probably a 1 to 2% progression of venous symptomatology in a year. In the UK now, it's rather old data, but in 2013, nice guidelines were published, and what is interesting to note is that these were in full concordance with those of the USA, Europe. And the key thing is that all patients who have bleeding varicose veins should be referred to a vascular service, but the key thing is that patients with symptomatic primary or recurrent varicose veins should be referred, as should leg ulcers, patients with superficial vein thrombosis. If we look at what has happened since the publication, we can see that there's been no real referral in the pattern of referral of C6 disease, but certainly there has been an increased referral patterns of people with lower class and also an increase in endothermal ablation. However, this is an NHS-funded healthcare service, and what is interesting is you can see that we have guidelines which are commissioned, and it's only those areas in green that are following these guidelines, whereas other areas are restricting the use of interventions to maybe C4, 5 disease. And I think what is really quite important is that there is a hierarchy looking at endothermal ablation first, then foam sclerotherapy, then surgery, and the key thing is that you should not offer compression hosiery to treat varicose veins if treatment is suitable, And looking at the NHS data, this has happened. There have been recommendations now for the newer techniques of endovenous mechanical ablation and glue that are now standard recommendations by NICE. NICE came out with various research recommendations, and you can see that the COMETA trial and the AVOLS trial and the Michigan PA trial have sort of looked at the cost effectiveness of the role of hosiery in the treatment and also the role of phlebectomies. But there are some key questions there to which there have been answers to date. We're all familiar very much with the various treatment options for endometrial ablation, and we know that actually they are all cost effective, but some are more cost effective than others. And it would seem that laser ablation is the most cost effective. There are many truths that no technique is perfect. Surgery may be better for some. Endothermal ablation techniques are probably the same, but the important thing is to manage the patient expectations. In the UK, there is now a further thing called the Evidence-Based Intervention Programme, and they have fully adopted the NICE guidance to get the various payers to pay for intervention. However, this has been interrupted by COVID. If we now move on to look at various aspects of deep vein thrombosis and emboli, we all know that VTE is a significant healthcare burden, particularly in the hospitalized population. And around the world, there have been programs so that we can look at patients' risk and see if we can identify high-risk groups and offer them appropriate prophylaxis. This is an example of the UK Department of Health questionnaire and also of the Caprini score that is often used in the United States. Venous thromboembolism is often a problem, and certainly in the UK, we rely a lot on the use of graduate compression stockings, and we spend around about £64 million on them. However, they are often poorly fitting, and there's often poor compliance. We've previously shown that actually there is no adjuvant benefit in surgical patients of adding in stockings if the patients are receiving molecular weight heparin. There are various other studies that need to be formed looking at graduate compression stockings to see if there is any adjuvant benefit in the emergency patient, in those who are receiving prolonged chemoprophylaxis, and for those patients who are deemed to be at low risk, I have no risk factors, is there any benefit of graduate compression stockings? And these are all subject to ongoing trials. The post-thrombotic syndrome is again another thing that is often pertinent and is managed in different ways. We know that the standard of care is good anticoagulation, and what is also important to note is that the use of DOACs early can actually reduce the incidence of PTS and increase quality of life. What is the role of thrombolysis? NICE recommends it's something that we should consider, whereas the CHEST guidelines very much suggest it is something that you should not do with a grade 2B recommendation against it. If you look at the data from the CAVA and the CAVANT and the ATTRACT trials, you can see very clearly that there really is no benefit in terms of PTS other than at 5 years in the CAVANT trial. There has been, following the ATTRACT trial, there's been some discussion as to whether it reduces severity and decreases symptoms early on. However, what are the medical legal implications? Because there's certainly in the UK, as there's no really proven benefit, should you actually offer it as a... We did a survey and people felt that actually it was medically legally justifiable to use thrombolysis. But is it cost effective? That is something we yet really need to know, and probably it is a treatment option that will be dominated. If we look at mechanical intervention, such as the use of stockings, both NICE and the CHEST guidelines recommend against the use of compression hosiery for people with DVT, and this is based on the SOX trial, which showed no clinical effectiveness. However, there were many people who have suggested that there are many trial problems with this. This has led us on to go and perform what is called the CHAPS trial in the UK, which is similar to the SOX trial, and this is an ongoing trial at present. If we then look at the post-thrombotic syndrome and the role of iliac vein stenting, one of the questions is this actually a cost-effective treatment? There is really no good evidence in favour. A review that we conducted suggested that it may be of some value, but we really do need some good RCT data, and you can just about speculate that it may be cost effective in treating patients with leg ulcers. So there are many challenges ahead, and I think it is important that we think about these. What is also important is how we actually deliver care, and we need to think about this very carefully. And what do we think about personalised medicine? Personalised medicine is something that is undoubtedly new and is here to stay. There are various avenues with respect to research, and I think it is important that we think about where the next steps with respect to research, and that venous disease is very similar to atherosclerosis inflammation. And there are lots of things that are being done with respect to the genome and genome. Who should deliver venous care? Well, the answer is it should be a team who can conduct a full clinical and duplex assessment and offer a full range of treatments. What's important is the vascular surgeons actually need to take on the management of venous care and maybe not leave it to people. It's interesting to note that if you look at vascular interventions, venous interventions are far more common than arterial interventions. It's also important that we should all be recording the outcomes of our interventions. And how should we train people? As I've said, in the UK, it's very much a vascular surgical speciality, but around the world, it is evidence that many other specialities may actually be offering treatment for patients, and the key thing is appropriately trained. You'll all be well aware that there was a international collaboration looking at who should or should not be treated during COVID, and there were guidelines that were developed which I think were applicable to many healthcare systems. Thank you very much for your kind attention.
Thank you, Alan, for that overview and explaining what we all need to do, what we're doing, and it's all ultimately comes down to doing something that's tailor-made and based on quite robust evidence. And we will now take the questions from the audience. And is there any question from the audience? If there's any question, please come over to the speakers there. All those who have presented are present online. And if there are any questions, yes, I see Deepak. Please go ahead.
I have a question for Alan. And actually, we've been missing you here, Alan. This is probably the first Venous Association.
Sorry, Deepak, question is for?
Sorry, this is for Alan Davis.
Alan.
Alan, we're missing you here. We're probably the first Venous Association of India conference that you're not attending in real time. Okay. Thank you so much for coming in the virtual mode. I have a question for you. Is there a policy for preemptive prevention of varicose veins in women who are pregnant? You know what I mean? Is there a data that says that if you have, say, wear class 1 or class 2 stockings in the first or second trimester of pregnancy, they can actually prevent varicose veins? Because most of the varicose veins that we see in young women is postpartum. So is there any preventive role? Is there any evidence for that? Thank you so much.
Alan, you are muted. Alan, could you unmute yourself and talk?
As I know, I am unmuted. Can you hear me now?
Yes, we can hear you now.
As far as I am aware, there really is no evidence to suggest that prophylactic measures in pregnancy do anything to reduce the chances of the development of varicose veins or venous incompetence. However, I think there is some evidence to suggest that ladies do get some symptomatic relief during their pregnancy through wearing the stockings. So I think that, to the best of my knowledge, that's where the evidence is. NICE very clearly suggests that hosiery is the one treatment option that is available to pregnant ladies. And just to comment on that, I'm very sorry that COVID and all the various travel arrangements have actually stopped me from coming on. I know things are getting better, and I sincerely hope I will be able to come and join you all in person next year.
Thank you, Alan. The question for Peter. Peter, thank you for joining us. I know you're busy with AVT. Are you seeing a decrease in the number of open varicose veins operations in the public system? And
Yeah, I think we are, but I think it's not gone completely. There's a lot of push for, funders in both the public and private sector to try to reduce funding for, surgical ligation, stripping, but there still is a role. And I think the society, the ANZ Society of Vascular Surgery, is really keen to ensure that, and I think all your speakers have reflected this, that there are specific indications for those techniques. If those techniques disappear, then I think we are the poorer for it. I think if our concern is not so much about the reduction in open surgery, but rather the high numbers of venous stenting that's occurring. And I think Alan Davis has already mentioned the evidence is sparse, but the pressures for using venous stenting to try to minimize post-thrombotic syndrome without evidence is a big problem. It is a problem that I think countries like Australia, where we have access to venous stents and IVUS, etc., we have to take responsibility. The evidence base must be there. But surgical ligation, Prabhu, still remains an operation that we do.
Right. Peter, are you seeing an increase in venous stenting for NIVL, for the May Turners, as compared to the post-thrombotics?
So I think that's the troubling data we've seen from the Australasian vascular audit, that, a significant percentage of data recorded in our audit is for May Turners, NIVLs, and it, the criteria for diagnosis of May Turners remains, uncertain when we look at the data. So yes, Prabhu, I think that is a concern. Our concern also is the fact that this is occurring in the private sector, where there's less data capture. So as I said in my talk, I think, regardless of the procedures you perform in whatever specialty, there has to be a strong evidence base. It has to be focused on outcomes. And I think the work, the NICE guidelines and CHEST, which Alan has published, are really the sort of thought leaders in terms of us appropriately using, these expensive technologies.
Thanks, Peter, because we've just been doing the same thing. The discussions have been reducing the frequency of venous stenting. So thank you, Peter. We have one more question from the floor. Ilya Kumar.
This question is for Dr. Javier from Mexico. Excellent talk, sir. One small question. In the evaluation of this patient with PEBD, that's the term what we have just pelvic venous diseases. Your investigation of choice and any diagnostic criteria you strictly follow, that was the first part of the question. And patients with asymptomatic, particularly pregnancy, those pregnant women who come to you with these problems, what will be your line of management, including a diagnostic criteria, if you have?
Hello. Okay. Do you think in pregnancy patients?
Yeah, having pelvic venous disorders.
Okay, we have the patient in pregnancy state. We can offer to the patients the compressive therapy. After to the pregnancy, we can study to the patient and we can offer another kind of treatment because we need to be so invasive with this patient.
Yeah, thank you. But the first part of the question still remains. What is your investigative modality in normal patient with pelvic venous disorders? You prefer imaging, like perineal ultrasonogram, or?
Okay. The first study is to perform the ultrasound
And do you have
The
any
transvaginal
ideas for
ultrasound
those?
is the best option to these patients.
Thank you.
Last question to Patricia. We noticed in your presentation that women seem to get more foam sclerotherapy and men get intravenous ablations. Is there a reason for the difference of treatment between men and women?
Yes. In our experience, we saw that we have better results in women than in men. And I think this is due to the different kind of vein wall. Especially in young men, you have much more the muscle part of the vein represented than in women. And that's the same reason why we prefer to perform sclerotherapy also in bigger veins in the older patients, because these patients has normally really very thinner vein wall, so they respond really very well to the this kind of treatment. This is our experience.
Thank you.
I know that there is not a really a scientific explanation in this. We have some work by Whiteley in which we see that if you can obtain a completely destroyment of all the three layers of the vein wall, you can obtain better results in sclerotherapy. And I think that the difference stand in this. You have much more muscle layer in men than in women. In the vein wall.
Thank you for that.
So I thank all the 5 speakers, Peter, Patricia, Javier, Sandeep, and Alan, for being here with us today and giving an international flavor to a conference that usually would have seen you in physical presence, but that's all the more better to have it this way too. So please, thank you again, and thanks for being with us. So good night.
Thanks very much to everybody. Bye.
Bye. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you, with all my pleasure. Bye-bye.